Hello and welcome. My name is Angela Aguirre. I'm a recent UC Davis graduate with a major in neurobiology, physiology, and behavior. My research project is on how the timing of arterial testing affects outcomes for patients with lower extremity wounds. The research was accomplished by myself, Aman Aurora, and the PI, Dr. Misty Humphries, through the School of Medicine at UC Davis. Patients with critical limb ischemia and concurrent wounds suffer higher rates of amputation. An ankle brachial index, or ABI, is the standard practice for screening peripheral artery disease in patients. Our study goal was to determine if high-risk patients who received an early ABI were less likely to receive an amputation later in life. Higher-risk patients of lower extremity amputations are associated with certain types of diseases. These diseases include peripheral artery disease, PAD, or diabetes mellitus, DM, while having both PAD and DM further increase the risk of amputation. Our methods consisted of collecting data from 90 patients with arterial disease referred to the vascular clinic from 2018 to mid-2019. 7 patients were excluded due to no follow-up appointment. Of the 83 patients, 22 were excluded due to the absence of a lower extremity wound. 61 patients were included in the final analysis. The groups were differentiated into an early ABI group with an ABI time less than 30 days from initial referral, or a late ABI group with an ABI time greater than 30 days from initial referral. We found that 14 patients received an early ABI test, while 47 patients received a late ABI test. The results show that 26 of the 61 patients had no pulse exam performed by the primary care provider when the wound was identified. Patients in the early ABI group were more likely to have a pulse exam done at the time of diagnosis, 78%, than patients in the late ABI group, 49%. Patients in the early ABI group had faster time to referral, revascularization, and wound healing. Patients in the early ABI group also had decreased risk of major amputation, although this did not reach statistical significance. Table 1 shows patient characteristics and outcomes. For the early ABI group, the mean age was 69 years, while the late ABI group, the mean age was 70 years. In the early ABI group, there were 10 participants with diabetes, 6 participants with coronary artery disease, and 3 participants with COPD, chronic obstructive pulmonary disease. In the late ABI group, 33 participants had diabetes, 16 participants had coronary artery disease, and 8 participants had COPD. The mean time to vascular referral was 17 days in the early ABI group and 165 days in the late ABI group. The mean time to revascularization was 48 days in the early ABI group and 101 days in the late ABI group. The mean time to wound healing in the early ABI group was 141 days, while the mean time to wound healing in the late ABI group was 349 days. Figure 1 shows time to amputation for patients with early versus late ABIs. The black bar represents the early ABI group, and the red bar represents the late ABI group. The early ABI group had decreased risk of a major amputation compared to the late ABI group. However, this did not reach statistical significance. Here are the conclusions based off the data thus far. Many patients with lower extremity wounds do not have appropriate pulse exams performed in the primary care setting. Early ABI testing can identify patients that benefit from revascularization and expedite specialty referral. Larger cohort studies are needed to determine if early ABI testing can decrease major amputation rates. Further directions for future studies include expanding the years of cohort to include more patients, and the use of Medicare or all-payer data to determine effect of ABI testing. Thank you for your time and watching this presentation. Please ask any questions regarding the research. We are still collecting data and hope to increase the number of participants included in our study.